Hello, this video will review the principles of shoulder arthroscopy. The outline for today is to discuss the indications for shoulder arthroscopy, the operating room setup, we'll review the patient positioning, and the complications associated with arthroscopic shoulder surgery. With improvements in technology and instrumentation, arthroscopy has become the primary treatment modality for many shoulder disorders. Compared with the traditional open techniques, shoulder arthroscopy has allowed for smaller incisions, decreased risk of deltoid muscle damage, improved intra-articular visualization. Many patients experience less pain postoperatively, and there's potential for faster postoperative recovery. As a result, both surgeons and patients have demonstrated a preference for shoulder arthroscopy. Complication rates are relatively low, reported to be anywhere between 4.6 to 10.6%. Some of the indications for arthroscopic shoulder surgery are listed below. In this slide, we can appreciate the arthroscopic tower on the left. The video and power equipment stack holds all the recording, monitoring, and documenting equipment, along with the shaver power source. On the top right, the Mayo stand holds instruments in the front side of the patient. In this picture, we can appreciate the arthroscope, the shaver, and the radio frequency device. In the image to the bottom right is an arthroscopic fluid irrigation and pump system. Unfortunately, this is different than the one used in Calgary. The most commonly used arthroscope for shoulder arthroscopy is a 4.0 millimeter 30-degree arthroscope. Most cases can be completed using the 30-degree scope only. A 70-degree arthroscope should always be available in the room, however. A 70-degree arthroscope can be especially useful with humeral avulsions of the glenohumeral ligament lesions, for remplissage techniques, for distal clavicle resection, or arthroscopic assisted corticoclavicular reconstruction. Intraoperatively, while performing a shoulder arthroscopy, the surgeon requires active measures to control bleeding to enhance the visualization. Obviously, a tourniquet cannot be used in these types of surgeries. Direct control of bleeding points may be controlled with the use of electrocautery devices or by locally infusing vasoconstrictors. Indirectly, we can control the bleeding by minimizing the fluid pressure differentials between the patient's blood pressure and the pressure of the infused fluids. This is done by a combination of lowering the patient's blood pressure if possible, and rising the pressure of the fluid being circulated. Unfortunately, when these techniques fail, the culprit is often due to the turbulence of the blood within the fluid in the shoulder. This brings us to the discussion on Bernoulli's principle. The Bernoulli effect explains the negative pressure gradient that develops perpendicular to the high velocity fluid stream, creating a suction effect towards the stream. The Bernoulli effect is essentially a consequence of the Bernoulli's principle, which states that a fluid stream creates a force perpendicular to the stream that varies inversely with the velocity of the fluid stream. A classic example can be found in the bathroom with the bathroom shower. When the shower is turned on with the shower curtain drawn close, the curtain is pulled towards the stream jet of water because of the negative pressure gradient created by the Bernoulli effect. At a certain point, defined as Reynolds number, flow can become turbulent. Factors that affect this transition from laminar to turbulent flow include suction or pressure gradients. Essentially, this creates a situation analogous to that of the bathroom curtain shower. Moving on with patient positioning and anesthesia. The two common positions that we perform shoulder arthroscopy are the lateral decubitus position and the beach chair position. Essentially, patient positioning is typically determined by surgeon experience and surgeon preference. First, the lateral decubitus position. Some of the advantages of this position is the increased visualization of the glenohumeral joint and subacromial space without the need of an assistant to apply traction. Regardless of the arm position, traction should be limited to 15 to 20 pounds. Unfortunately, the incidence of nerve injury has been estimated to be up to 10%. As for the beach chair position, it was developed in an effort to avoid the neuropathies seen with the lateral decubitus position. Some of the proposed advantages are the lower incidence of neuropathies, the decreased risk for neurovascular complications during portal placement, decreased surgical time, easier conversion to open procedure, better visualization of the joint. Unfortunately, the beach chair position comes with its own possible complications, which are mainly the difficulties with maintaining proper cerebral perfusion and adequate airway control. In an awake upright patient, the sympathetic nervous system is stimulated, which increases vascular resistance and mean arterial pressure while decreasing cardiac output. Unfortunately, under a general anesthetic, the sympathetic nervous system cannot effectively respond to the upright position of the patient, which causes a relative decrease in vascular resistance, a reduction in mean arterial blood pressure, and a greater reduction in cardiac output. Despite the advantages in hypotensive anesthesia in limiting blood loss and maintaining a clear view during arthroscopy, there is just a milieu where the cardiac output must be necessary to maintain appropriate cerebral perfusion. Lastly, we'll discuss the complications in shoulder arthroscopy. Complications are best conceptualized in reference to when they occur, meaning preoperatively, intraoperatively, or postoperatively. Complications associated with arthroscopic shoulder surgery can be minimized with careful patient selection, thoughtful consideration of surgical indications, appropriate patient positioning, detailed knowledge of shoulder anatomy, and judicious use of anesthesia. What can be done preoperatively is to appropriately select patients with appropriate surgical indication. What is meant by this is not performing a shoulder arthroscopy procedure when an open technique would be more adequate. As for patient positioning, malpositioning can lead to significant preventable soft tissue injury and neuropraxia in both the upper and lower extremities. In fact, patient positioning may be the leading cause of complications related to arthroscopic shoulder surgery. Surgeon participation at this stage ensures optimal orientation of the patient for the procedure, adequate padding of bony prominence, and appropriate protection of the neurovascular structures that are vulnerable to injury. Intraoperatively, one must be aware of the neurovascular injuries that could occur. The axillary, suprascapular, and musculocutaneous nerves are the most vulnerable to direct injury. As for neurologic events, stroke, central nervous system infarcts, and vision loss associated with shoulder surgery have all been reported. And these events occurred almost exclusively during arthroscopy performed with the patient in the beach chair position. Postoperatively, infections are quite rare, ranging from 0 to 3.4%. The risk factors are similar to those of other orthopedic surgeries, including obesity, diabetes, smoking, peripheral vascular disease, and immunocompromise. In addition, The shoulder is vulnerable to specific subsets of bacteria, such as P. acnes. Lastly, the risk and incidence of thromboembolic events following arthroscopic shoulder surgery are extremely low. Because of the reported incidence of these complications, there is minimal high-quality evidence in the literature to develop strategies for prevention. In addition, the incidence of thromboembolic events with the use of beach share and lateral decubitus position is equal.